the cavity.
Yes.
Ultrasound still shows the cavity, but we don't continue with the antibiotics because the cavity takes time to fill with the granulomatous tissue, and it will require much more time. At times it requires months. So ultrasound, presence of cavitary lesion on ultrasound in a case of liver abscess is not an indication for continuation of the antibiotic. That's a cavity. We have treated the pus. Now gradually granulation tissue will fill up.
So that's not the end point of treatment?
No, that's not the
end point of treatment
clinical
is clinical
monitoring,
symptoms.
clinical monitoring,
Right.
and maybe if you go for the leukocytosis and CRP, that is the end point of the treatment. Like no fever, return of the appetite, no tenderness, no abdominal pain. This is the.
So are there any?
Yes, sir. That can, not in that cavity, but the reoccurrence can be there in less than 5% of the cases. If the child is immunocompromised, some inadequate treatment has been given, adequate dosing has not been given, and still there are, like if we have missed, like I talked about, if we missed bacteremia, suppose we miss the bacteremia that is seeding the liver hematogeneously, and if intra-abdominal abscess is somewhere there and that is causing the liver abscess, and at that time we can recurrence again. No, actually, it is not the dental caries. In every dental caries, we need to look for the liver abscess. In a case of, what I mean to say is, in a case of liver abscess, one must thoroughly examine the child from head to the toe to see is there any evidence of bacteremia or not.
Okay. Are there any mimickers for this condition that you might be misguided or misled?
Yes, sir.
Another diagnosis may be sitting over there.
Yeah, there's another interesting case which I would like to share. This child presented with abdominal pain and fever for about 12 days, 14 days, and went to the surgery emergency. There was a definite rebound tenderness, pain in the right iliac fossa. They were planning for surgery for appendicitis. Subsequently referred the child to us for our opinion. When we got an ultrasound done, that showed the liver abscess. Basically, a liver abscess, there was no evidence of any appendicitis on the ultrasound. So whenever a liver abscess is there and that is irritating the peritoneum, that can mimic as a appendicitis at that time. So around the take-home message is that liver abscess can mimic the acute abdomen, and early imaging can avoid unnecessary surgeries.
Thank you very much, Dr. Manish, for having us enlightened with all these informations which you have shared with us.
Thank you.
Moving quickly to Dr. Sanjay Swarup, who is a renowned pediatric orthopedic surgeon, and most of us have yes.
Sir, choice of antibiotics, generally when we give the intravenous antibiotics, initially we give ceftriaxone along with vancomycin. This we give for 14 days, along with the metronidazole. Metronidazole is generally given for 10 days. Generally, books mention that for amoebic liver abscess, you require metronidazole, or for pyogenic liver abscess, you require ceftriaxone and vancomycin. But in this is most of the time true in adult cases. But however, in pediatric cases, we have found the mixed infections. So we give ceftriaxone, vancomycin along with the metronidazole. We don't give metronidazole more than 10 days because it leads to neuropathy. We stop IV antibiotics after 2 weeks, and subsequently for next 3 to 4 weeks we give the oral antibiotics of oral amoxicillin.
So we move on to the bone infections, the hidden infections in the bone, and I'll ask Dr. Sanjay Swarup to start with his cases by which he is going to convey the important messages to us.
Right. Thank you very much. It's a privilege and an honor to be here amongst all of you. So I'll just quickly move on. I have just 2 cases to show you, and this is the first case. It's a child who is 4 years old, and he has been limping for 4 days. He had sudden onset pain in the left hip after play. At the moment, he has a refusal to walk, and his temperature was 100 degrees. He had a history of URI 3 weeks ago and now settled, and there is no history of any significant trauma. So based on this history, we decided to look at the child, and we said, well, the child, he's a 4-year-old who is obviously in some degree of pain, so he's not cooperative. Hip movements are possible, but they are not painful. But he has a restriction of internal rotation. And internal rotation flexion also causes the pelvis to move. That means he has some degree of guarding. And he is irritable. Oxygen saturation is normal. He has no toxemia and is otherwise normal. What is your impression? Do you think this is heading towards a septic? Okay. Okay. So is this going towards a septic? What is your impression? Or is it an irritable hip? How many people think it's an irritable hip? Okay. And how many people think we should rule out a septic arthritis? Okay, a lot of us. Okay. So let's go to the next slide. So we decide to do some bloods. His TLC is 10.5, CRP is mildly raised, peripheral smear shows mild leukocytosis, and blood culture was negative after 72 hours. His ultrasound examination, which is up here, shows a moderate effusion, and his MRI scan is also showing a moderate effusion. How do we clinically determine whether we are heading towards a septic arthritis or we are heading towards, or is this just an irritable hip? So, this is the big question. And so we take the help of, next slide please. Next, yeah. So there are Cocker's criteria which are clearly defined when he says that there is fever which is more than 101, or ESR more than 40, or TLC more than 12,000, and a refusal to weight bear. When you have these 4 criteria, then there is a 99% probability that this is a septic arthritis. Cocker CAD modification is CAD added CRP, because in the initial, at your first contact, your ESR is not elevated really in most children. So he's added CRP, but he says, Cocker says, if there are 3 criteria which are positive, then you have a 94% probability, 2 criteria, only 40%. So 3 or 4 criteria are important to take you towards septic arthritis. But in Cocker CAD modification, he says if all 5 are there, then again, there is a very high possibility that this is septic arthritis. So an irritable hip will settle down very quickly in a couple of days. The toxemia will be mild, and you should not be worried if your Cocker's criteria help you to determine clearly whether it is an irritable hip or a septic arthritis. Now I want you to show the second case, a proper case of septic arthritis. So this is a 9.6-year-old female. She was febrile for 2 days. Fever went to 104 degrees, increasing pain hip on the first day, and she had refusal to wear tape. She was admitted to the hospital ICU because she became breathless. So obviously this is a full-blown infection happening which has got systemic ramifications. So you are thinking very quickly that this is septic arthritis. But this is what happens, and it's very typical, and we see this very often. Next, sir. Now TLC was 22.5, ESR was 34, and CRP was 9. Blood culture was 10, and
Just give us 2 minutes more.
2 minutes. Started on IV antibiotic. Next, sir. Next slide. 48 hours, patient was in shock, vital support, intubated, high-end antibiotics, blood culture said MRSA. She was shifted to our ICU after 5 days, intubated. MRI of the left hip was done. That was the first thing we did, and we found that there is a large effusion and edema of the capital femoral physis and the neck femur. Now she is basically a case of septic arthritis who went into a septic shock. So immediately we decided to do an arthrotomy and pus drainage. There was rapid reversal of symptoms and additional procedures were required, but then slowly she started recovering. Next please. When you look at her hip 10 months later, it's the left hip. It's completely destroyed. You can see the shape is gone, there are big lytic areas, there is an impending pathological fracture, and the hip has subluxated. Next please.
Can you move to the next slide, please?
Yes, please.
Allow me to, I'm asking the organizers. Next slide, Niyari.
Oh, they have stopped.
Yeah, now it's there.
Okay. And
Yeah.
when we did an arthrogram, the hip is completely misshapen. Now this hip is destroyed totally. And so we have missed that window of opportunity to operate on this patient in time. That is where the big message comes here. Next, please. I would not go into this because we are short of time. So, next, please. Next. Yeah. Now, when there is sepsis and your patient child comes with septic arthritis, then you know that that is the cause of the sepsis. And early diagnosis is very important. and you must always use an MRI really early in the game. You are managing, you are firefighting, you are trying to save the child, but remember the cause is the pus that is sitting inside the hip, and early surgery is cornerstone of the treatment. If you do not drain that pus, the child will continue to be moribund, and we often see this that in ICU setting also, in ward setting also, pediatricians try to manage the child first, symptomatically, try to make them stable. In trying to make them stable, that window of operating them in within 24 hours is gone. The hip is destroyed and you get huge morbidity following you for many days on the ward. That is the main message. So outcome of surgery depends on its timing. That's the main.
Right. Thank you very much, Dr. Sanjay, and all my panelists over here. You've done a wonderful job and conveyed the message very clearly and very crisp way. Over to the chairpersons.
Thank you, panelists, and for a wonderful and, you brought the key messages in a very short period of time. And I think so, in the interest of time, brevity of time, we'll end this session. Thank you.
Thank you so much, Dr. Taneja, Dr. Chugh, Dr. Saroop, and thank you so much all the chair